This is episode 258 of the Rio Grande Foundation's Tipping Point, New Mexico. I'm Paul Gessing, president of the Rio Grande Foundation, New Mexico's free market think tank. You can find out more about the foundation at riograndefoundation.org. I am pleased, nay, I am ecstatic to be joined this week by return guest, Dr. Deane Waldman. That's Deane. Waldman, Waldman. And I say that and spell it because if you want to know more about Dr. Deane Waldman, you can find a lot more at his website, Deane Waldman, Deane, Waldman.com. And he has a lot of information on healthcare policy. And welcome to the show, Dr. Deane.
Very pleased to be here.
Now, I will not do you justice if I describe your many credentials. You have many of them when it comes to the medical profession. We're going to have a wide-ranging discussion today on not just the topic of COVID-19, but of course, we have a new administration in Washington. You have your ideas.
Maybe.
Well, probably. We'll see. But we more than likely have a new administration. But, even if Trump is the guy, we can talk about what we should be doing instead. But anyway, talk about your name and credentials by that name.
My mother accused me of being a professional student, so I actually liked school and training, so I was in training until I was 34 at all sort of the appropriate schools. Medical school, undergraduate at Yale. Actually, John Kerry was a classmate. I'd rather not go there. So was Fred Smith of FedEx, by the way. George Bush was 2 years behind us. Anyway, trained at all the sort of good places, became a pediatric cardiologist. Also, for this discussion, should point out that along with those other training events, I also trained as a pathologist, which plays into knowledge of COVID and what it means. I became the chief of cardiology at the University of Chicago, found that I didn't really know what I was doing as a leader, a manager, in charge of a $20 million business. So I went back to school at the age of 55 and got my MBA. So that's another qualification when I talk about money and healthcare policy and things of that nature. And for the last many years, for almost 40 years, I was a pediatric cardiologist and loved pretty much every minute of taking care of the babies. Didn't like the system, loved my patients. And last many years, I've been working in healthcare policy, trying to treat the healthcare system as though it were a sick patient rather than a broken machine. And that's a very actually important way to look at things.
Now, for the lay people like myself, when it comes to these medical terms, the term pathologist. Now, we know pathos is not, I believe, a Greek-rooted term. Correct me if I'm wrong here, but definitely when you hear somebody described or something described as pathological, it generally involves not telling the truth. So we know it's not a good thing. But what is a pathologist? What are your
a
expertise?
Pathologist is somebody who studies and analyzes the mechanism, the biology, the physiology, the mechanism by which illness occurs and, quite frankly, death occurs, so that you're not just trying to say, well, he died of an automobile accident, or which, by the way, one of the COVID deaths was an automobile accident. But the question is, why did the person die? What actually caused the illness, if you have an illness and you're alive, God willing, or if you die, what actually caused, what series of events? Was it heart? Did your heart stop? Did your lungs fail? Did your brain cease to function? Things of that nature, and that's what we study.
Excellent. So you clearly have some insider expertise knowledge about the issue at hand that's affecting all of our lives, our economy, our kids' schooling,
Mm.
etc. So, talk, just take it. Talk about the COVID-19 pandemic and, you know, any aspect of this that you want to share that you think is relevant for our listening audience.
I'd be happy to do that, although you touched on something when you asked the question, which I wanted before I get into the real issues, which is our children. A total of 1,568 New Mexicans have died in the last 10 months, at least attributed, we won't say due to, but attributed to COVID. Of that number, one was a child. And that was a child who had a pre existing condition because he actually was a premature baby and had chronic lung disease. My point is the risk for children by every statistic in every state is so low that um, they clearly have some degree of natural resistance, call it immunity, call it whatever you like, but the risk of a child dying from COVID is so low that I'm much more worried about being hit by the school bus than I am COVID. Therefore, our children should be in school. They should not be denied their schooling. And the long term consequences of, especially in this state, of not having children getting their education is really going to be harmful. Now, let me talk. You wanted to talk about COVID, so we'll talk about situation as a pathologist. The fact is, people talk about COVID deaths. Those are people who die with the virus, and therefore, or at least the viral particles on the test are present in their blood, and therefore they are attributed to death by COVID virus. That is wrong by every measure we want to name as a pathologist. The question is, when a person dies, does he die with the COVID virus but died because of something else, or did that person die because of respiratory failure due to occasionally it's actually his heart failure, but the majority of deaths because of COVID are from respiratory failure because it's a respiratory disease. It's a respiratory virus, and it causes your lungs not to work right, and you can't exchange CO2 and oxygen, and you fill up with water, and you don't have enough oxygen, and all your organs fail, and that's what respiratory failure due to COVID would be the mechanism of death. Having said that, what you need to know is that data from the United States, we'll get to Italy in a second, data from the United States shows that 73% of people who died attributed to the COVID virus actually had some very serious comorbidity, or if you like, pre-existing conditions such as cancer or a cancer survivor. But if you're a survivor, your immune system is profoundly damaged from the chemotherapy. Chronic lung disease, 24% of COVID deaths were deaths in patients with diabetes. My bottom line issue here is that most of the deaths attributed to COVID were deaths because of something else, and they had the virus when they died. And that's a very important narrative that is not getting out into the public.
It's seemingly by design almost.
Well, I'm not much of a conspiracy theorist. Having said that, I agree with that inference, which is I fear that there was a political motivation behind this mass hysteria that has been promulgated mainly by the mainstream media, but unfortunately, the leaders of our medical establishment, at least the ones that are talking, I'd rather not use names, tend to war, talk around the truth, the biology, and the true danger of this disease. And the true danger for the general population is extremely low. For the high risk population is very real. It's probably on the order of 15%. If you have, chronic lung disease and you're in heart failure or kidney failure and you're 85 years old and you're in a nursing home and you're debilitated, yeah, you're at real risk from this virus. But you're at real risk from another virus as well. God knows you're at risk from tuberculosis. There are lots of things that can injure you that won't injure you, the
Hmm.
high risk person, that won't injure Paul Gessing. Okay,
How
so
about Deane Waldman? And you're
well,
a little older than me. I'm not going to tell people how old you are. You're in by my estimation, we know each other for a better part of a decade. You've always been in good health, but you are retired pediatric cardiologist. That at least helps people understand.
okay, I'm 77 years, but here's the problem. I don't have any pre-existing condition. So and I'm in, quite frankly, very good shape. My blood pressure is 112 over 70. I exercise extensively.
Do you wear a mask when you ride your bike? I know
Uh,
you're a big
the
bicyclist.
That may be the ultimate ridiculous mandate I've ever seen. To tell me to wear a mask so that I can breathe more of my carbon dioxide in and get less oxygen when I'm out there training on my bicycle is insanity. Not to mention there ain't nobody around me. Anyway, let's not go there.
All right, fair enough. I think we got your
So
point.
the real bottom line for me is what we should have done in the first place. I'm saying the nation, but especially New Mexico. What we should have done is we should have said, hey, this is a serious problem for the high risk population, and we have to talk about the Native Americans. Don't let me
Hmm.
forget that. High risk for certain populations. Otherwise, we should let this thing go so we can develop herd immunity.
Hmm.
And that's the best protection for the high risk population. It's not even a vaccine, even though a vaccine is a good idea for the high risk population. But the best is to have 100% protection by herd immunity. And that's what we should have done back in March. We could argue February, but certainly March. Meanwhile, our state, New Mexico, the economy has been intentionally, I'm sorry to say, crushed. We are the poorest state in the union, and we're just getting poorer. We have hundreds of thousands of people who want to work, and they're not allowed to work. Now, let me talk for a second about the Native American population, and that is if you look at the data which I brought with me on the frequency of cases, in other words, the case rate, um, what you see very quickly is that Native Americans have 4 times the likelihood of infection with COVID that the other populations do in our state. Okay. And I've got the data actually from the state database in front of me. My point is, well, should they be classified as high risk? And the answer is, I believe they should, given their propensity. But the propensity, people need to understand this. This is a medical statement I'm going to make. There are clearly genetic factors. It's not just poverty, it is genetic factors that play a role to make a population with a certain genetic makeup more susceptible to an illness. Example, in Japan, heart attacks are actually rather rare, but gastrointestinal cancer is rampant. It is a common illness. And I trained with a Japanese physician in medical school, and he said he was really looking forward to seeing these patients with heart attacks. He said, "Well, we don't see them." And then we'd have a patient with a GI cancer, which is not common but not uncommon. He says, "Oh, I've seen dozens of those. There's no." My point is, different genetic populations have different propensities to illness and different abilities to protect themselves in terms of immunity. Therefore, it is reasonable that it is a genetic predisposition in the Native American population, and therefore they should be classified as high risk.
And you mentioned China and Japan, I believe, both there. And something I've noticed, and this is a little bit outside the box, but hear me out. So, China is, of course, where this all got started. Uh, and basically, my assertion here is that you talk about genetics, and it's always fraught to get into the area of genetics. But in a medical context, I think sometimes you need to. It seems like Oriental Asians have some specific ability to fight against this particular virus because China, 3 deaths per million. Now, we could argue they're cooking the books, maybe, Chinese government, but we talked about Japan. They're at 13 deaths or 18 deaths per million. Now, India has struggled with it, but there are other Asian countries, Malaysia, 12 deaths per million. Uh,
And our country is,
sorry?
you got the data
Oh,
there.
we're at over. Let's see, United States. We're one of the top countries in the world at 871. So to give you an idea, yeah, there are no Oriental, and I only use that distinction because India has been hit hard, but nobody thinks of
I,
Indians
I see
and
where you're going, and
Chinese.
the answer is, to me, the same as I said about a minute ago, which is different genetic populations have different um, biology in the sense of their immune systems, their cancer rates of different types of cancer, the incidence of chronic lung disease. Now, does the environment and diet play a role in this? Absolutely, it does. All I'm saying though is you can change your diet, you can change your, whether you exercise or not, but you can't change your genome, at least in today's world. And so I think that what you're suggesting is correct, namely that there are genetic differences, and that's not a political. It gets taken as political, identity politics and so forth. But that's a medical statement of fact, not disparaging the black population or the white population or the Asian population. It's none of that. It is simply the biology of our genes.
Yeah, and there's other Asian countries. I look Cambodia. They don't even list deaths per million. Laos, an incredibly impoverished, war torn country. Same thing. A lot of African countries, very very small numbers. So yeah, we could go down that rabbit hole for a very long time, but I'm going to pull it back there, and we'll kind of go with a brief kind of recapitulation of where you think we should go now, or where, generally speaking, we should have gone
Okay.
originally. Because obviously, we came into this in March. We didn't really know a lot of the contours of the virus. Maybe the 2-week lockdown made sense. Maybe it didn't. You can tell me if you think that was a bad
The,
idea from day one. Where's President Deane Waldman taking us if you were
I can
in
I can
office?
I can say categorically that what was that? I think it was Ulysses S. Grant. If nominated, I won't run, and if elected, I won't serve. There is no job on earth that I would like less than being the president of the United States. And thank you, but no thank you. Having said that, if you want to make me the medical czar, which I'd be willing to accept
You are the
briefly,
Fauci.
please, no, no, thank you very much. But Scott Atlas, yes.
Okay.
Fauci, no. We need herd immunity. Now, people have denigrated the phrase, well, we can't have it, or it's too dangerous, or things of that nature, and that's complete BS. Now, as I said before or I alluded to it before we started this recording, we what was it last week? The Chinese, of all people, came out with a study in Nature that I could go through all of the biology because it's really very interesting from my standpoint. But the bottom line is very simple: people who are infected and then recover, whether they're asymptomatic or they're symptomatic, but they had the infection, They develop antibodies. This has been proven multiple times. Have herd immunity. They are immune and therefore cannot transmit the disease, which is what the study shows. So, long winded, indirect answer to your question, what should we have done and what should we be doing now? Well, sure, we should vaccinate the high risk population now that we have a vaccine. But what we should have done back in March, certainly March or April, is we should have allowed the virus to infect the general population. We should offer quarantine, quite frankly, strict quarantine to the high risk population. This is a free country. If you're 80 years old and you don't want to quarantine, it's your prerogative. In my opinion, we should not be living under this dictatorial system, which not only have we had now, but Biden intends to lock down more and to make masks a national mandate. Talk about ridiculous medical. A lot of data shows that masks are either not helpful at all or only minimally so. Um, anyway, herd immunity can be acquired, and I think we are now, with this quote third surge, probably acquiring herd immunity, and we should not continue the lockdowns. We should let people go back to work. We should certainly let our children go back to school, and we should offer quarantine to the high risk people. That includes Native Americans, that includes children, a cancer survivor who's 50 years old. Absolutely, that person has an damaged immune system and should be vaccinated first and should be quarantined until we have the vaccine spread out. And we should allow our country to recover, to go back to the robust economy, the schooling that was working. That's what we should be doing.
All right. And I know you have broader things to say about American healthcare, prospective Biden administration, et cetera. But uh, you mentioned masks, and I can't totally leave that subject because we've talked about masks and their relevance before, but I would say that Wally and I, who appear on this show regularly, would call ourselves we're not in the anti-mask community. I certainly wear them inside when I'm going into the big box store, partially just because the stores themselves say you need to have them, and I'm not one to fall on every single sword. Sometimes you just got to pick up the detergent and the croissants, and you don't want to cause a scene. But what's the Deane Waldman policy
I
on masks?
I think that they have become a religious talisman as well as a virtue signal. Having said that, I do, when I go into a store or a restaurant, in order not to cause them distress, the store people, because they're under the gun. If they don't follow the rules or try to follow the rules, they could be fined, they could be closed. So out of deference to them, respect for them, I wear a mask. Having said that, I don't wear a mask at home. God knows I don't wear a mask when I'm out training on my bike. My next door neighbor, oh, interesting. My next door neighbor is a cancer survivor. She had lymphoma and she underwent chemotherapy. When I'm with her, I wear a mask. Okay? Why? Because I think that maybe it will reduce what small chance there is for her to get the virus, because I don't want her to get the virus. But this business about ratting out your neighbor because he or she is not wearing a mask is just like the Salem witch trials. Hello. And, Cuomo has pushed this thing, and Newsom in California. And I think, I'm sorry to say this, but I think these people are on a power trip. And, crisis is a terrible thing. Firstly, this isn't a crisis, but it has been made out to be. But a crisis is a terrible thing to waste. Now, let me do something that I said I would before we started, which is um, that herd immunity. I want to get out there the simple fact that herd immunity has been shown in basically every other virus that we have experienced in the last 150 years of knowing something about epidemiology. And there's no reason why we can't develop herd immunity in this country safely.
Okay.
And I'll leave it at that. If you want to go on and talk healthcare reform and Biden, or for that matter, Trump, I think this would be appropriate time.
Yep, that's the plan. So, uh, Deane, you've obviously written a lot and talked a lot about healthcare reform. We had you on the podcast, I don't know, maybe a year or so ago, and we talked about your efforts in that area. I guess since it is the new thing out there, but to me, and I think you, it's probably more of the same. But we should talk about Biden and what he has in store for us, broadly speaking, on healthcare policy. So, our governor is not going to be the HHS
Yes,
secretary, but if a miracle happened and you had been tapped somehow to be I know I keep wanting to send you to Washington D.C.
please.
Javier Becerra, the
Yes,
Attorney General of
California.
California, is going to be in that role. But what would you be telling Biden, or what's your reaction to his uh, initial plans? Obviously, healthcare was kind of one of those issues that the Biden campaign really focused on as a perceived weakness in Trump's record. So, what's your take on what he has in store for America?
Firstly, he has, Mr. Biden has put out a Biden health plan, which I have read. God knows I've read and studied and written about the Medicare for All, which we have to talk about at length in just a second. But the Biden health plan basically is Medicare for All light. It is still a further incursion into the. It has price and wage controls, for example, just the way Medicare for All does. But rather than Medicare for All literally prohibits private insurance, what he says in his plan is, oh, well, we're going to give them the public option. And so the public option effectively is a government health insurance plan scheme, and it's a insurance company, the government, paid for by tax dollars. Well, what are they going to do as soon as you form this public option? Well, they're going to put out insurance at some price less than whatever United Health or Cigna or whoever, any private company can possibly, and they're going to offer, and so they're literally going to drive private insurance out of the market because they control, they have the backing of tax revenue. So what's going to happen in a frankly short period of time is there's not going to be any private insurance. So effectively, you're going to end up the same place that you were with Medicare for All. Now, second point, and I will discuss Medicare for All in just a second. But second point is that I believe that Mr. Biden, you'll forgive me, is, shall we say, more of a figurehead than he is a driver of policy with his own opinions. I don't think he really has them. And I believe that Kamala Harris is going to have a huge say in this. And by the way, Becerra is just like Kamala Harris. He has been on record as being a fervent supporter of Medicare for All. So my prediction is, assuming that he does take the Oval Office, and that these people are in power, namely Kamala Harris and Becerra for Health and Human Services, I think they're going to make a big push for Medicare for All, and that's what I see as their plan in the first several years of their administration. For people to understand this, the this is a real sham. This is a true fraud. It is Medicare for all is sold as well. It's simple. Everybody has insurance, Medicare, which is of course false because Medicare is a program that you paid into, and Medicaid is what it should be called, Medicaid for all. But be that as it may, because it's free at point of service. You don't pay into it, you just pay huge taxes. But what will Medicare for all do? It will eliminate all private insurance. So your only option as an American will be government, whatever the government allows you to have. Number two, it has literally price and wage controls so that the government says how much it'll pay the hospital, how much it'll pay the doctors. According to several studies, the physician's reimbursement will be dropped by at least 40, repeat, 40%. So your pediatrician literally will go out of business, and all non-surgical procedures will just cease to exist because you won't be able to find a general doctor because he's paid less than the truck driver who brings the Enfamil to your pediatrician. So there will be price and wage controls. The shortages of physicians and other providers will increase dramatically. Wait times will become months to years instead of what they are now, which is 4 months to see a general physician. But they'll say, oh, well, this is a real simple system and it'll be user friendly. Well, I defy any listener to name one efficient, user friendly government bureaucracy. I mean, you really need to look at for example, the Affordable Care Act. The first set of regulations was 10,515,000 words. Okay? The Bill of Rights was 492 words, and the regulations for Obamacare were over 10 million, and the organizational chart is worse than the road system in Los Angeles. It's so confusing and so expensive and so complex. My point is that government bureaucracy always expands and makes it harder for the end user, namely a patient or a doctor, to actually use the system. So this business, oh, it'll be a simple system, and doctors who support Medicare for all we really want to do is take care of our patients, and at the end of the day, get paid. That's, I mean, and what happens is the doctors are so frustrated with the system that we have now, which is terrible. It's very complex. Every day, every physician is fighting with some insurance company to get his or her patient what the patient needs. So the simplicity, the touted simplicity of, well, it'll be a real simple system, be just one form and you can take care of your patients. And well, that's baloney because according to Medicare for All, the government decides what treatments I can give a patient or not, when the patient will get it, the wait time, the drugs that I can use or not use. It doesn't matter what I think is best for the patient. What matters is what the government allows me to use. My point is, Medicare for All is total government takeover at an enormously expensive cost, and taxes will, at a minimum, double, unless people think I'm exaggerating. By Bernie Sanders, the cost of his Medicare for All plan is $40 trillion. Now, the total GDP of planet Earth is $90 trillion. So he wants to spend almost half of the gross productivity of our entire planet on a healthcare system that won't provide care. And obviously, I feel passionate about this. And on the other hand, I want people to know what they're really buying rather than what they're told they're getting. I mean, if you ask any
Let me jump
Democrat,
in real quick.
yeah,
Sorry to
yeah,
you're rolling and you got incredible information there. But we talked about Obamacare when that was going
yes,
on. In the left, the Bernie Sanders types wanted this public option,
right,
and so talk about. So I'm gonna give you a two-parter because I know you can handle it. One is talk about the failure of Obamacare on its
okay,
face and the fact that here we are, 4 years after Obama's left office, and the left, the Democratic Party, Biden, his vice president,
yep.
are already pushing for more far-reaching reforms of this, what I believe is a failed healthcare law, and talk a little bit about that. And if you can, I know most of our listeners, we are the most informed 0.05% of the population, certainly here in New Mexico and arguably around the country. But talk about, Medicare, Medicaid, what it means that it's Medicare for all, not Medicaid for all, and kind of, maybe how this compares with a Medicare for all system would compare with some of the other systems around the globe when it comes to healthcare. Because of course, Canada has a single payer system. I mean, we're assuming that it's going that direction. So I know that's almost 2.5 parts, but go ahead and take it away.
Okay, it actually is easier than you think. Both, well, multiple Democrats have said they want to, and I quote, build on the success of the Affordable Care Act, or also known as Obamacare. The problem with that is the one success that it had was that it gave, repeat, gave, it didn't, it at a price to the rest of the tax-paying population, it gave free insurance to somewhere between 10 and 12 million Americans who at the time were not insured. So the number of uninsured people went down, which in theory is a good thing. The problem is that the purpose of having a healthcare system is not to insure everybody. And that's what they keep saying. Well, we need to have everybody insured, 100% of the American population. No, the purpose of any healthcare system is to get care to people. So if the insurance leads to timely care, then great, that's wonderful. But if the insurance actually doesn't lead and get the patient the care he needs or she needs when she needs it, then the system of insurance is not working. So, Obamacare increased the number of people with insurance, and at the same time, and I have data to prove this, there's no argument here, and at the same time, it increased the wait times for people to see a doctor and the number of physicians who accept Obamacare insurance went down. So, what ends up happening is you have more people who expect to get care, and those people, all people, have less ability to get the care. So, this business with building on the success of Obamacare is just fallacious. The fact is, Obamacare failed at its primary function, which is to increase the care delivered to Americans. And that's why when you said it's a failure, you're absolutely right. And oh, by the way, even though it failed to give care, it increased the cost of insurance to the rest of the population more than double. The if you want silver plan, so there's so many plans that it's hard to say what an average is. But the average American family prior to Obamacare in 2009 paid 12,000, and I forget the exact numbers, $12,000 a year for healthcare costs. Last year, the average American family of four paid $28,166. That's a third of the median income. Gross income went to mostly insurance companies. It didn't go even to providers. So it went to bureaucracy and insurance companies. So my whole point on your first question is Obamacare failed in what really matters. It didn't make insurance more affordable, which of course was promised, and it decreased the ability to get care. And whether you have insurance or not, what the hell difference does it make if you can't get in the doctor's office? So Obamacare is clearly a failure, and to say that they're going to build on its success is a very sick joke. Now, you asked about Medicare and Medicaid. People tend to lump them together as the two big entitlements. Excuse me, they are not both entitlements. Medicare has been paid into by working Americans for, well, since 1965. And some of us are old enough to have been paying in since 1965. So I've paid in a lot of money into the Medicare trust. Medicaid is free insurance. It is paid by taxes, supported by tax revenue, not by my contributions as a working American. Now, Medicare, oh, well, Medicare, everybody loves Medicare, and Medicare is a great system, and we want to extend it to all Americans, Medicare for all, except for the minor little problem that, according to the Medicare trustees, not me and not some partisan politician, the Medicare trust fund will go broke in less than 6 years. So in 2026, if you are going to depend, unless something radical changes, which, in Washington, that's not going to happen, in 2026, a senior who's dependent on Medicare for his hospital care is going to find he can't get care because there's no money. So you want to extend this to Medicare for all? Forgive me, are you crazy? You want to extend a insolvent system that can't provide care to all Americans.
We're going to have to leave that conversation there. And unfortunately, we don't have much time.
Sure.
But say President Trump does get back to the Oval Office, or the next Republican president, or heaven forbid, a Democrat who gets the free market.
What should be done?
What is Deane Waldman saying
That's
needs to
simple.
be done? And I'll just reiterate, you have all kinds of great resources at DeaneWaldman.com. Great videos, etc., detailing some of these things.
Yes, the answer is, I have studied this extensively, financial modeling and so forth. The book, Curing the Cancer in U.S. Healthcare, is the answer. And the answer is very simple. If you are an American and you are now paying $28,000 last year, $28,166 into the insurance companies, I say no. Put it in an HSA, an unlimited HSA that you can transfer to your children and grandchildren, whatever, if you don't use it. And every year you put in $28,166. What's going to happen? And then buy catastrophic insurance, very high deductible, so that if, God forbid, you have a heart attack or you're in an automobile accident and you have this very expensive medical event, you are covered because you have catastrophic insurance, which, by the way, is very cheap if it's high deductible stuff. Meanwhile, you go out and shop for your own care and pay for your child's vaccinations and your mammograms and your routine checkup. Now, if you did that, if we had that system, what would happen? Well, the people who sell mammograms would have to compete with each other. Well, some woman, I can, down the street, I can get a mammogram for $200, or I can drive 5 minutes, 10 minutes to that other place and get my mammogram for $50. Now, which one am I going to go to? Answer, you're going to make a decision based on your money. You're probably going to go with a cheaper one. And what's going to happen is the guy who charges $200 is going to find himself out of business, or he's going to lower his prices. The bottom line is free market forces when consumers control their money, and that's the key. When consumers control their own money, There is an incentive to economize, and sellers of doctors, hospitals, pharmacies have to compete for my dollars rather than compete for a contract, which is what they do right now. Um, when that happens, if that were to happen, that would solve 90% of our problems. Now, before
Oh,
you
okay.
wait a minute,
All right. All right. All
I
right.
got to
All right.
say one more thing, which
Perfect.
is, oh, the big excuse is, well, yeah, but what about those with pre-existing conditions and those who are impoverished? We had good systems in most states, and as a matter of fact, in New Mexico, we had a very good system of a high-risk pool that worked well. You ask any of the patients, don't ask the bureaucrats, ask the patients, and they'll say this high risk pool really worked well. I got good coordinated care. So, those with pre existing conditions, we can have a safety net for them based on the states, not from the feds. And that's my answer.
Perfect. All right. Well, I've already cited your website, so folks go there. He has some videos, a lot of other information. He occasionally writes into the Albuquerque Journal and has op-eds published there. So thank you very much, Dr. Deane Waldman, for your expertise and information today. And thanks for listening to this week's show. Make sure to get the latest edition of Tipping Point New Mexico by subscribing on Apple Podcasts, Stitcher, and Spotify. You can post or comment on this and other episodes on Facebook and Twitter, and tell Google Home to play Tipping Point New Mexico. Thanks to Path 3 Marketing for producing this show.